Don't ignore your inner voice. We all, through our experiences in medical school and residency and being an attending, we all see wonderful things that we latch onto and we want to replicate. And then we see things that might be questionable or you're uncertain about, or you feel like there might be a better way to do that. And over time, you accumulate those ideas and experiences, and it becomes an inner voice in your mind where you feel like, I can do this differently, or there's a need for me to do A, B, C, and D, or I'm going to be curious about what else is out there. And so I think not ignoring that inner voice, but actually trying to define it, because most of the time, most of us that want to do something different, we know we want to do something different. We kind of have some ideas, but we don't have an objective plan for how I want to do.
Do you utilize technology AI in your practice or remote monitoring or wearables and things like that?
I love AI, and this surprised me. I'm a perimenopausal middle-aged woman, can't teach old dog new tricks kind of person. And, so let me just tell you about my EHR system, which is just fabulous. So it's a completely AI integrated system. And what is it that we all hate doing? We hate documentation. We hate administrative burdens. We hate writing prior authorizations and going through patient forms. We hate all that. All we want to do is see the patient, right? Or do things that are meaningful for patient outcomes. And so if I have a system, which is what I have, where it listens to our conversation. And then when I say extract data, when I press the little button, it converts my conversation with the patient into an HPI, and it puts appropriately the stream of consciousness that just went on between me and the patient into social history and past medical history and the list of medicines they've tried before. So it has this all written out for you, and I haven't had to do a peep on the computer to write anything. Now, it does do also, my particular system does also do an assessment and plan. That is the one thing I completely erase and do on my own because AI is not good at that yet. The differentials are too broad and sometimes esoteric and not appropriate for the patient because the AI cannot, even though I'm doing the exam and I'm narrating the exam for the patient, it's not really incorporating that information, but it does everything else. But that saves me time. So I'm seeing a patient within 5 minutes, my note is done and I can move on. And then the medicines that I ordered, I need to do a prior authorization. My AI system just completes that for me. And then when I get a referral, I press extract data, and then this AI will build the patient chart for me. I don't have to do anything. It'll take the patient name and date of birth and their email and their address and it puts all that in there and creates a chart. So I don't even have to create a chart. My front desk can be free to do other stuff that I need them to do for checking in my patient. And my favorite part of this AI system, you can tell how excited I'm about using AI in my clinic, is that sometimes you get these patients. We have Mayo Clinic nearby, and we have Barrows and Honor Health, these big academic medical centers. And these patients will typically come in with 200, 300 pages of documents. Well, my AI system will extract the data and summarize it into a page. And then I can cross reference this to ensure that the AI got the information correctly, as opposed to spending that time, which is it's a very labor intensive, as you know, effort to go through all these pages. And so that's made me a super efficient physician, which is something I pride myself for a long time. I've always been a super user for every EHR system I've been on historically, but to now not even have to be a super user, I just rely on AI that I can then just cross reference and double check has made medical care so much more pleasurable because I'm not doing that administrative burden. Now, the second corollary to AI is the thing you mentioned about wearables and the patient endpoint AI. I'm using more of a hybrid model for that because, as you know, in the world of neurology, we're seeing patients as young as 18 and into their 80s and 90s. So my 80s and 90-year-olds, some of my older patients are not as savvy with some of the technology that we have, but my younger patients are, and I encourage them to track some of these metrics, provided they don't have anxiety associated with tracking metrics, because that can be a problem. But for example, if you have somebody tracking their sleep metrics and they're so stressed about going to sleep and having the good numbers for the percentage of REM and deep sleep, they'll actually end up paradoxically hurting themselves by staying up all night worrying about what their metrics are going to be. But for most people, it's been just a wonderful feedback to be able to look at their heart rate variability, to look at the resting heart rate and their blood pressures and how much REM and deep sleep they have. And there's certain foods and supplements that can optimize increasing your REM sleep, which helps with memory, versus deep sleep, which helps with the lymphatic system. So I can really, game biohack their using their wearables. I can biohack and optimize their neurologic function.
Sounds like you're using AI really well.
Love it.
It
It is
was
my favorite.
I know. Shala and I did an episode recently on AI and talking about whether AI will replace clinicians in the future. What are your thoughts on that?
Another really good question. And I think so. The thing we have to resolve is that AI is inevitable, right? It's happening in front of our eyes right now. And we can either accept it and incorporate it with us as an adjunct, or we can, deny it and then fall behind as clinicians. Because clinicians who don't use AI, they will fall behind. Now, AI is never, in my opinion, going to be good enough to replace the experience. Maybe some of the more black and white, more objective fields like maybe surgical, and then you'll have technicians that are overseeing these surgical procedures. But when it comes to neurology, it is so complex and we rely so much on the physical exam and kind of pattern recognition from all the prior patients we've seen before, and from some level of intuition and assessing not just the exam but also their the biomedical data and the family history. I think it's too complex for AI to replace that. And I actually see that with my fancy AI system, which I think is top of the line with my electronic medical records. The assessment and plan, it's never quite gets it right. It's very mechanical and it's very rudimentary thought processing for the assessment and plan. And that is something I would expect maybe a medical student level. Now, AI can refine itself and it's probably going to get better, but it won't be from the patient doctor interaction standpoint. It's going to be from optimizing pattern recognition and reading MRIs, for instance. So right now you can tell a difference between a seasoned neuroradiologist reading your MRI from a new graduate from residency reading your MRI, right? You and I, we've seen that difference on the report. But if you give this new graduated resident an AI boost system, so all of a sudden this resident that has low experience becomes an expert level neuroradiologist because they're utilizing this pattern recognition that the AI system has been fed in by thousands, if not millions, of prior studies. So then we can narrow down that gap from experience to inexperience, but never replace, in my opinion, never replace the actual radiologist or neurologist or whatever specialty.
AI is going to be interesting. I hear that a lot of physicians who use AI, they're very happy because it is increasing efficiency. But what do you think the institutions will do? Is it going to be, okay, you have AI and you can see more patients now, but compensations will stay the same for physicians? Private practice level, it's very helpful and useful. But on the institution levels and organization levels, we have some concerns.
I hope I'm not being negative, and this is not, the ex-Yugoslavia, ex-communist country thinking coming through here. What's going to happen is you're going to have the AI-based systems with mid-levels and technicians taking care of most of the population in some kind of a socialized medicine system. And then those who have a higher socioeconomic status and they can actually, they can actually afford an expert physician that is using AI as an adjunct, they're going to be paying cash for their services to get these better outcomes. So I think institutions may turn to AI, but they're going to have worse outcomes, but more standardized approach, right? But then you'll have these subspecialized bougie medical clinics, these concierge clinics, fee for service clinics, where those who can afford it, they say, oh, I'm not going to this institution. I'm coming to Dr. Powell, or I'm coming to, whoever.
I don't think you're being pessimistic because that's basically what Shala and I were saying as well. I mean, you already see it happening, right? I feel like those who can afford it now are going to direct primary care
Yeah.
or are going to concierge medicine. More and more, it's going to be AI, nurse practitioner, and maybe like one physician supervising like 30 or 40 visits during the day. It's just going to be squeeze, squeeze, squeeze. So it's already happening.
One silver lining, if there is to be a silver lining in all this, is that patients are becoming real savvy. They're figuring this out. As we have patients that are advocating for us, not as much as we want to be, but is growing.
How do you approach wellness for yourself, your family, in your life, day-to-day life?
Yeah, so it is a non-negotiable. And part of it is not because I'm a big enforcer of wellness in my household. It's because I just continued living the lifestyle I grew up in the Balkans. And so we naturally will eat. I don't know if you girls have heard about the American Gut Project, which was done. It was started in 2012, and it resonated with me. It's kind of a slightly gross topic, but the scientists decided to collect stool samples across Great Britain, United States, and I think it was New Zealand or Australia. And he collected stool samples. And then he had, and it's not a randomized controlled clinical trial, just observational study. But he then would send out these surveys for what are your, what conditions you have, what diseases you have, what are you being treated for, and what kind of foods you eat. Give us your dietary like a log that people ate. And what they found was those who ate 30 or more different plant foods per week, they have optimal health metrics across all measures. They had less dementia, less stroke, less inflammation. Their CRP numbers were normal, ESR. And at the time that he was doing this, COVID is starting to kick in 2020. And what they found that across these numbers of patients or subjects they're looking at, those who consumed 30 or more different plant foods, they had the same rates of COVID, but they never went into the hospital. These people just picked up COVID and just, it was like a regular cold and got over it and moved on. And so that resonated in me because growing up in the Balkans, that's what we do. We eat so much diversity of vegetables. I mean, one soup can have 12 different things in it. After I have breakfast, lunch, and dinner, you're chewing on parsley because it's supposed to help digestion or whatever. So you're always eating this big diversity of foods, and fermented foods are a big component of our lifestyle. And so it was nice to have that study support the outcomes and to encourage me to continue doing what we did in our family, which is we eat this large diversity of foods. We're always curious of new foods. My kids, ever since they're little, they're comfortable eating Indian food and Thai food and Vietnamese and Korean food. That we ferment a lot of foods at home. So there's no alternative in our household, but we're not perfect. My kids just 10 days ago, Halloween, they brought in 26 pounds of candy. 26 pounds amongst three kids. So I let them have a little bit of candy, but you have to earn it. You have to do your exercises. We're very physically active. They do sports. We prioritize sleep. We're very obsessive about sleep. I think my kids have inherited my genetics where they have to be in bed by 7:30, 8 o'clock. I go to bed around 9. But if they don't sleep enough, they don't feel good the next day. So they themselves have learned to prioritize sleep and hydration. So wellness is just part of our normal life, and education has been part of what mama does anyways. And we always look at the packages and, okay, if we're going to eat this Butterfinger and it has high fructose corn syrup, we talk about the pathways for why high fructose corn syrup is not optimal compared to just regular sugar. And so my kids are already aware of that. So it's been a pretty easy pathway, I would say. And the key, I think, for if I was to recommend anything to any parents out there, is you don't want to restrict too much, because if you restrict, eventually these kids are going to move out of the house and they'll go off to college, and now they're going to gorge on candy that you've been restricting them. But if you educate, then they empower themselves to make choices that are wise, and they try to moderate their intake.
That's really helpful information because I know a lot of the times it gets difficult when you're trying to balance implementing all of these things that are helpful, but you're still having to go to work and do all of these additional things. So, what do you say to people who are interested in preventative neurology as patients, but say, I just don't have the time, or I don't have the money or the resources to do this? Can I do this?
Yes. So that is where I think I have the talent. That is where I believe is the reason why my patients will fly from various states to see me, is because all we have to do, if I have an average patient that doesn't have a medical background, and I tell them the American Heart Association recommends that you exercise 150 minutes per week and you should eat a Mediterranean diet because that has the most studies that's been shown to be optimal for brain health, and you send them off, well, that is just a whole bunch of words that have no meaning to them. And like you said, if they're busy, sometimes you have a single working parent, or they're holding two jobs, or they're doctors like ourselves, and they, have all these night shifts and responsibilities and different things. It is not feasible for them to do that. If I spend that 5-10 minutes and I assess you where you're at, then I can give you a bite-sized approach that I can build upon from every visit that I have with you. So if I have that, 62-year-old patient that doesn't work out, well, for them, I can say, listen, you don't have to add a workout. That takes a lot of money. You have to pay for a gym membership and buy workout clothes. I just want you to park your car at the furthest row possible so you can walk extra 5 minutes to get into the grocery store instead of not. Or when you go in the morning to grab your mail, I just want you to walk down to the end of the street and back and just do that for until I see you next. And if that's been successful, then I'll add an extra little bite size exercise snack or a certain food approach or whatever. But the key is to not to overwhelm the patient. I do have a few my engineering accounting types that want to be overwhelmed. It's like, no, give me everything. I'm going to do it all. But those are rare. And so I have to recognize where my patients are in their social system and their work environment. Do they have the time? Do they have the money? And based off that, I can make small, meaningful changes that can actually impact their health because we all know small, meaningful changes over time will give us more results than intensive, impressive efforts that you do for a month or two, then you burn out and you give up on.
In our household, we try to be very healthy. I cook food a lot, but I was counting 30 plant food. I was counting in my hands, like, do we really do 30? So I need to get a list of,
Yes.
the 30 plant foods that
Yeah.
we need to incorporate in our diet.
Let
But
me
yeah,
give you a
we're
little
not
hint.
asleep.
Let me give you a little hint how to simplify it. So it counts if you add the different herbs. So if you cook a soup and you add, little potatoes and legumes are a huge component to the healthy diet. Legumes are just such powerhouses for making the short chain fatty acids in our gut that have wonderful modulation for neuroinflammation and just general health. But always trying to have some sort of legume in a day, beans, lentils, chickpeas, whatever, and then adding herbs. If you add oregano and rosemary and cilantro, that all counts. So it all counts in adding that diversity. And so then when you realize you're like, well, actually most of my salads, as long as I'm not just doing lettuce, bib lettuce and I'm done. But you add a little potato. I mean, you add a little tomato, you add a little kale, some cabbage, a few herbs,
Avocado.
avocado. You got 10 things in your salad. And then a simple measure, which I know you probably do already, is if you have to add fat to your food, always go for olive oil. If you need that high smoking point, go for avocado oil, and that's it. So I keep it simple because you're right. If I tell someone eat 30 different plant foods, people are thinking, oh my gosh, I have to have a 5 course meal every night. I got to cook all this, And I tell my patients, no, we're just roasting a bunch of vegetables. We're making a salad and then cook a soup and cook enough where you can freeze half of it. You can pull it out for the next weekend, and that way you make it easy peasy. And then of course I'm very big into empowering my children to cook. So as soon as they're old enough to cook, my youngest is 7, my oldest is 13, they help. So I assign them to cut and prep and wash, and it's part of me brainwashing my children to know how to do this. So when they go off on their own, they'll continue this lifestyle. But part of it's because it really helps and makes my life a little easier and offloads some of that responsibility. But yes, it can be done. It takes a bit of um, being willing to eat different foods. And I don't want to generalize the American lifestyle, but I have plenty of patients walking into my clinic who are, for all intents and purposes, very healthy. But when I ask them what their dietary log is for the week, every morning they have oatmeal and every day they have broccoli, which are wonderful, healthy foods, but it's so monotone. It's so single source that they're not getting that big biodiversity that helps bring in the big biodiversity of the microflora that American Gut Project showed is important. And so optimizing that and just helping our patients look outside and eat the foods you may not like, but over time you'll learn to love.
My kid's pediatrician says the rainbow, right? Eat the rainbow diet, all the colors.
Patient once come in because I told him, eat the rainbow. And he was so funny. I know he was joking with me, but he walked in the next visit and said, Dr. Powell, I've been eating the rainbow every day. And I was like, oh, this is great. Tell me what kind of foods you're eating. He's like, I had Fruit Loops every morning and they have all the colors. And I laughed so hard, but I think he was half joking, half truthful. So we had a heart to heart with that. But no, you're right. Eating the rainbow, that's it. Finding the colors, the more intensive the color is of the food, go for it. If you have a white cabbage versus purple cabbage, go for the purple cabbage. If you have regular orange versus blood orange, go for the blood orange. Because it just happens that nature gave us these hints. The more intensive the color is, the more phytochemicals it has. So all the foods are really good for you, but the more color we have, the more bang for your buck you get from that food.
Yeah, I hope that my kids don't pick up on the Fruit Loop.
Yeah, don't listen to this part, kids.
I know. So, how do you see the future of preventative neurology for the next 5 to 10 years?
Gonna be standard. I don't actually foresee. For a while I was, why is it that we don't have a preventative neurology fellowship? And then I realized, what kind of world would it be where you have a preventative epileptologist and a regular epileptologist, right? That makes no sense. So I think it's going to be the standard. And I see it already happening to some extent with cardiology. I think our cardiology colleagues have been a little more aggressive about doing the preventative approaches with their patients. Uh, I think they recognize the importance of not having to wait till things need a cardiac surgery, but actually trying to avoid that surgery if we can with preventative approaches. So it's going to be standard. It's going to take time because it's not just the patients already demanding it. The physicians are already hearing the data across all specialties and they're interested in it. But it's that, again, the crux of the problem is the medical system that doesn't recognize preventative approaches in a way that can be reimbursed or covered for in a clinical setting. So that is our limitation. But as soon as that changes, I think we'll see this becoming the standard and not a specialty.
What advice do you have for physicians who might want to shift their career from hospital medicine or whatever they're doing? As we discussed, it's getting harder and harder to practice as a hospital physician. What if they want to do a specialized niche, be it preventative or whatever? How should they approach that?
Yeah, so a couple of things. And this is just how I approach things. So I'm just translating over to what has encouraged me to make the change. And that is one, don't ignore your inner voice. We all, through our experiences in medical school and residency and being an attending, we all see wonderful things that we latch onto and we want to replicate. And then we see things that might be questionable or you're uncertain about, or you feel like there might be a better way to do that. And over time, you accumulate those ideas and experiences, and it becomes an inner voice in your mind where you feel like, I can do this differently, or there's a need for me to do A, B, C, and D, or I'm going to be curious about what else is out there. And so I think not ignoring that inner voice, but actually trying to define it, because most of the time, most of us that want to do something different, we know we want to do something different. We kind of have some ideas, but we don't have an objective plan for how I want to do. And then the second part of that inner voice, and that's our subconscious telling us what to do, is that we need to be very careful not to take someone else's voice as our own. And this happens in training, in residency training, and even in medical school so much. We've all had these wonderful, well-meaning, you know, experienced mentors that tell us this is the end all be all, which is typically stay in the academics. And again, academics are great for some, but for a lot of us, only consider academics if you know what else is out there. So be curious, be open minded, and don't get it in your head that you must do academics, which usually means you must do a fellowship training. Now, and I say this from an interesting place. I had to grow into this comment because I, as a active duty military neurologist, had an opportunity to apply for a fellowship. And there's a period of shame that I went through because I did not get that fellowship. And here I am, a general neurologist. I'm going to be just this general neurologist because I was denied the fellowship in neuroimmunology, which I still love to this day, but I'm actually really glad that I can still take care of those neuroimmunology patients and take care of everybody else. But in the military, there's this hierarchy, and I'm sure the civilian world has it too, where if you apply for a fellowship, but there's someone more senior to you that's already been deployed and they already have these multiple levels of leadership experience ahead of you, of course, there's no way that a newly graduating resident is going to get that fellowship over this senior physician. So it completely made sense. But when I got shipped out from my duty station um, outside of Walter Reed to my first duty station as a general neurologist, I did carry some shame with that. Here I am in an academic medical center through the military, and I'm just the general neurologist. And then I started asking myself, well, wait a minute, I'm seeing everything. I'm going from ER to the hospital neurology patients coming back to my clinic to take care of the dementias and peripheral neuropathies and the migraines. So I'm doing everything. that is actually a superpower. This is a wonderful thing that I can do. And in most military situations, and then of course being back up, Alaska eventually, that is what we need. In our community right now, as it stands, we need more general neurologists. But because the inner voice was formed by those, manufactured by those around me, which was academics, subspecialized, stay at the center that you're trained in, I felt that I wasn't fulfilling the role I was supposed to. And instead, I just went off and just became a general neurologist. And nowadays, we all know general neurologists are like unicorns. I can't even find, I'm in this big city here, in Phoenix and Scottsdale, and there are so few general neurologists. Everybody I meet is a subspecialist, which is wonderful. But I couldn't do what I am doing here at Longevity Neurology Center if I was a subspecialist. Because the role of me opening up this clinic is I have to be available for everybody, as opposed to, by the time a specialist gets a patient in their clinic, on average, they usually have had the neurologic condition for a little while, have seen a general neurologist, and they eventually get to the subspecialist. And theoretically, for most of the things that I can work on preventing, even if I'm seeing, let's say, an epilepsy patient, they have risk for dementia, most of it, so by the time I see them, it's too late. So I can maybe help preserve function, but not delay the onset of the disease. So long story short, I think it's really important to, have your inner voice, make sure it's defined by yourself and not by those mentors around you who mean well, provided that you're having a balanced view from what else is out there. And that's why I really appreciate this podcast you have, because, for most of our new graduates, unless they went out in the community and worked with community neurologists, they don't know that there's the world of research medicine and PI medical legal and locums medicine, and that you can be, a fee for service neurologist, or there's just so many options we can do. But those docs that are at the academic centers, only thing they know is academics usually, right? So they can't even give you good guidance for it. And that's why I really appreciate, I'm actually actively having any medical student resident that comes through, I'm saying, listen to this podcast, see what else is out there before you make your decision who you're going to become, because there's so much else that you can do.
We all have learned, as new grads from our first experiences. And then years later, we realize what happened and how, we changed, our eyes open.
Open. That's right.
There are so many situations that I have to even keep reminding myself that sometimes things happen for a reason. What you said about the fellowship, and then we just have to move forward. And later in life, we realize that it was for a good reason.
So, Tasha, where can people find you?
Yeah, thank you for asking that question. So I'm online at www.longevityneurologycenter.com. And the beauty of my system being fee for service is that patients can book online directly, no referral is needed. However, if they want me to reach out to their primary care provider, I can always get their notes from them. I'm also on social media. I'm slowly growing that presence. I'm kind of the old school neurologist that likes to just have a good website and hope that people will learn. But I'm growing my social media presence online through Instagram and Facebook, and my handle is at Longevity Neurology Center.
Thank you so much for being on this podcast with us. We learned a lot. And thank you to the audience. Thanks for tuning in to Be Empowered, the podcast. If you enjoyed this conversation, don't forget to subscribe, leave a review, and share with someone who needs to hear this. Stay strong, stay empowered, and we'll see you next time.